doctors, students, good afternoon and Assalamu alaikum. Dr. Hafiz, senior. Now, I would like the speaker of this session, please give him a big round of applause. Professor Dr. Aftab Mohsin, please.
Bismillahirrahmanirrahim. I'm very grateful to Heinocon who have sponsored this session. This is an industrial symposium. So it is not part of the academic program of the society, and I am the speaker for them. But when I was coming onto the stage, Professor Bilal Mayuddin said, "Ki, tu kinna level padhana hai sanu?" So I am going to share an anecdote with all of the audience before I go on to the main presentation. तो ये इस दफा जो है 30 मिनट्स हैं प्रेजेंटेशन के, तो 30 पे रखना है, तो नहीं 20 हुए नहीं है, 20 से शुरू हुआ है, 10 मिनट अलार्म के लिए। तो वो एक बंदा था, पार्टीशन हो गई, मुसलमान था, तो वो लाहौर आ गया अमृतसर से, पीछे एक सरदार जी थे, वो अकेले रह गए, तो उनका जो दोस्त था वो बड़ा पक्का दोस्त था, तो वो जब जाते थे वहां पे जो भी पब या बार थी तो शराब पीते थे, तो पहले एक तरफ टेबल के बैठते थे और फिर दूसरा गिलास दूसरी तरफ से जाके पीते थे। तो लोगों ने कहा कि सरदार जी आप ऐसा क्यों करते हैं? कहता है यार वो आफ्ताब मोहसिन सी वो टुर गया पाकिस्तान, तो मेरा साथी सी ते हुण वो चला गया उधर, ते मैं की करा, मैं एक ओदा वल्लों पी लेना कि चलो भाई ये तेरा हिस्सा हो गया। तो थोड़े दिनों बाद लोगों ने देखा कि सरदार जी अकेले ही पी रहे हैं एक ही तरफ से बैठ के। तो बिलाल मयूद्दीन वहां गया हुआ था कॉन्फ्रेंस पे, उसने पूछा सरदार जी है की गल है, पहले तुसी दोवें पासे कहंदे सी मैनू ते डॉक्टर ने मना करता, हुण ते आफ्ताब मोहसिन ही पींदा है। तो पहले वो मैं सईद हमीद साहब की जगह लेक्चर दे रहा था, अब मैं एज आफ्ताब मोहसिन यहाँ पे आपके पास हूँ। तो ये है on updates on hepatoprotection, and I have a disclosure and affiliation announcement to make before the audience. I have been affiliated with Heinocon as a speaker, for which I have never received any monetary reward or honorarium. However, the Heinocon, which is a subsidiary of Hilton Pharmaceutical and manufacturers of a drug for hepatoprotection, have made a small contribution to PSIM for this conference and for this lunchtime symposium. I was told by the younger audience कि आपकी जो पिछली speech थी बहुत complicated थी. So this is the general anatomy of the liver, and Professor Gyasun Nabi Saab, when he was making his presentation, he highlighted the common bile duct. And here in green is the common bile duct, which is labeled at the lower part on one side. So this, okay, this is it. And this is on the cartoon or the diagram. Thank you. This is what is ये पॉइंटर जो है ना, ये जब चलता है तो ये मेन प्रेजेंटेशन diagram of the cartoon. One is these Kupffer cells are the resident macrophages of the liver. Normally they detox the liver and they are responsible for cleansing of the blood which brings toxins. And when there is inflammation, Kupffer cells, when there is a toxin, especially alcohol, or then these Kupffer cells will start and become fibrous or fibrate producing cells. And the other cell which is most important are these hepatic stellate cells. Stellate cells. These are responsible for fibrosis in the chronic hepatitis. Whenever there is infection, the stellate cell will start producing fiber or the fibrous tissue. When there is a toxin, the Kupffer cells will start producing the fibrosis. And once one started, then after some time, the normal homeostasis break down and there is a crosstalk between these cells. Once the portal hypertension sets in, once the fibrosis begins, the normal homeostasis break down and there is a crosstalk and that leads on to the disease. गालिब का एक शेर है बड़ा जबरदस्त, मेरी तामीर में मुज़मिर है एक सूरत खराबी की. So within us is the whole program for apoptosis and of inflammation, but there is also homeostasis. लेकिन sometimes one overtakes the other. तो मेरी तामीर में मुज़मिर है एक सूरत खराबी की, हियोला बरके खिरमन का है खून गरम दहकां का. So both are contradictory, fire and the blood, but both are hot and they burn the body. There were in Greek mythology two gods, two sets of gods. The first ones were Titans, which were many thousands years ago. One of the god who was a Titan was Prometheus. He stole fire and gave it to the humans. He was a very friendly god for the humans. And the humans then made a lot of progress because of that fire. Ultimately, the Olympians, the second set of God, the later set of God, which were run or which were the head god was Zeus. He punished Prometheus. The purpose of telling you is that even at that time, people knew that liver has immense capacity to regenerate. So what Zeus did was that he sent his eagle to eat the liver of the Prometheus. So what would happen is that eagle would eat the liver of Prometheus during the day, and according to the myth, the liver would regenerate during the night, and as the punishment went on and on and on for years, the eagle would come again the next day to eat it, and it would regenerate again. Hepatic stellate cells. In chronic liver injury, they differentiate into myofibroblast-like cells, and they have a very high fibrogenic capacity. They then start putting fiber in the extracellular matrix, and then the crosstalk begins. Hepatic stellate cells are involved in the injury because of the viral infections. Kupffer cells because of the toxins. What are the causes of chronic liver injury? NAFLD, non-alcoholic fatty liver disease, and NASH. Today, it is the number one cause of liver disease. It has surpassed HCV and hepatitis B. 70 million is the total number of patients of hepatitis C in the world. And because of increasing obesity, the NASH and NAFLD patients are far more in the world. 240 million is total of hepatitis B. About 1 billion or 1.24 billion are the people who suffer from NAFLD or NASH, which is excess fat or inflammation in the liver because of fat. Then there is alcohol, drugs and toxins, autoimmune and metabolic diseases. The most important thing for a young doctor or for an undergraduate or postgraduate who is appearing in their exam is on the bedside to decide whether the cirrhosis of the liver is compensated or decompensated. If you tell to the examiner that it's decompensated liver disease, because the diagnosis is bedside, in decompensated, one of the 5 features will appear: ascites, edema, evidence of upper GI bleed, encephalopathy, or persistent jaundice in the setting of chronic liver disease. So presentation can be no symptoms, mild, compensated disease, or decompensated disease, and sometimes HCC and or death. In the decompensated disease, the symptoms are weakness, fatigue, dark complexion, and I said decompensation is upper GI bleed, ascites, swelling, and encephalopathy. ये मैं ही गलत चल रहा हूँ. And then occurs HCC and death. In patients with chronic liver disease, I told you hepatitis B behaves differently. Patient can directly go from chronic hepatitis to HCC without going into cirrhosis. That occurs in C also, but very rarely. C follows a set pattern when there is inflammation followed by fibrosis, cirrhosis, decompensation, HCC, and death. How do you detect or diagnose fibrosis? You do it on the ultrasound or MRI. And the best way to do it is MRE, but it's very expensive. Every time you get an MRI done, and those people who have implants, steel or cardiac implants, they cannot probably have MRI safely. The ultrasound is what does transient elastography, which is known as point shear wave elastography. Then with ultrasound, you can also do Doppler. CEUS is contrast enhanced ultrasound, which is very, very sensitive in making a diagnosis of fibrosis or cirrhosis. And then there is perfusion MRI, which looks at the function of the liver, looking at the blood flow. Then contrast enhanced ultrasound with other contrast agents can be done. Portal hypertension is one of the main things in chronic liver disease, and it is known as hepatic vein pressure gradient. When it goes beyond 10 millimeter of mercury, it is called significant portal hypertension. So how do you decide hepatic vein pressure gradient is difference between wedged hepatic vein pressure gradient and free. You pass a catheter into the hepatic vein, inflate the balloon, and that is, you check the pressure, it is wedged, you deflate the balloon, check the pressure, and it is free. The difference, if it is more than 10, it is significant. And surprisingly, this significant portal hypertension now can be assessed by shear wave elastography. If shear wave elastography suggests that the fibrosis or the strength is 21 kilopascals or more, they collaborate very nicely. There are many, many studies now where you can see if the pressure or the fibrosis is 21 kilopascals, it is equivalent to significant portal hypertension. And people with significant portal hypertension are those who are going to die, who are going to get complications, who are going to decompensate. And PSWE is point shear wave elastography, SSM is splenic stiffness measurement, and MRE is magnetic resonance elastography. Abraldis from Spain is a scientist, a physician who has published some brilliant data on statins. I start with statins. He said that if you give statin to patients with advanced liver disease, including fibrosis and cirrhosis, excluding decompensated cirrhosis, the risk of developing decompensation is tremendously reduced. The risk of HCC and death is tremendously reduced. There's a huge potential. I was attending a meeting of AASLD in September 2018, and there this data was presented for the first time. And there is a huge potential for use of statin in advanced cirrhosis and fibrosis. And there is no risk of having a hepatic decompensation because of the statin. Generally, people are wary of using statin in advanced fibrosis and cirrhosis कि कहीं liver toxicity ना हो जाए. ऐसा नहीं है, बल्कि in contrast, the evidence suggests that if you give statin, the patient will not decompensate or will not develop HCC and will not die. So this is a drug, statin, which is also hepatoprotective. And other drugs, non-selective beta blockers, they are also responsible for reducing rebleeding and mortality. EBBL is not responsible for reducing mortality, but excellent for reducing rebleeding. Rifaximin, no meta-analysis to suggest that it prevents or reduces mortality. Oral norfloxacin and our beautiful enoxaparin. I received it recently when I was admitted with COVID-19. And now there is tremendous data that patients with liver cirrhosis, advanced liver cirrhosis, if when they have been looked after by a gastroenterologist, EVBL, endoscopic variceal band ligation has been done, risk of bleeding has been controlled. If you give them enoxaparin for a period of 48 months, their risk of developing decompensation, HCC, and death is reduced significantly. नैश के अंदर टिश्यू मैक्रोफेजेस कुफर सेल है, एथरोस्क्लेरोसिस के अंदर जो एथरोस्क्लेरोसिस कार्डियोवैस्कुलर डिजीज है वो एंडोथीलियल सेल जो हैं वो टिश्यू मैक्रोफेजेस बन जाते हैं और वो करते हैं, और डिमेंशिया के अंदर जो माइक्रोग्लायल सेल्स हैं वो डिमेंशिया की फाइब्रोसिस करते हैं. तो with that in mind, people say that if you are treating hypertension to prevent heart disease, then you must also treat NAFLD and NASH to prevent cirrhosis and decompensation. NASH is a complicated disease. It is statins prevent it obviously, but there are many genes which are associated with it, and there is epigenetics, environmental factors. तो ये एक स्टडी है GWAS, आपको पता है, जीनोम वाइड एसोसिएशन स्टडी. इसमें they have identified 7 loci which are associated with NAFLD and NASH, and most important of them is PNPLA3. Now in the United States, they have found that 148 million people have PNPLA3, and this finding and similar findings have led to a thing called precision medicine. कि किसी में ये है तो उसमें वो दवाई असर नहीं करेगी अगर किसी को PNPLA3 है, या उसको significantly more effort करनी पड़ेगी in reducing weight to get the benefit. So precision medicine is medicine or intervention which is exactly according to individual patient, and you are going to hear more and more about it. I was working in United Kingdom in 1988, and my consultant would always tell me this story of William Withering. I was in Worcester, near Worcester, there was a small town called Droitwich Spa, and I was there, and there are 2 very important findings about Worcester. The post was shared between Worcester Royal and Droitwich Spa. The Imran Khan, our Prime Minister, our Prime Minister, not your Prime Minister, because you are in Azad Kashmir, would play cricket from the Worcester County. That was his first county. And that William Withering was a professor in 1775. He was a cardiologist and a physician, and he was going through that area, and he saw a patient who had fast atrial fibrillation, was in heart failure, and he said that she is not going to survive and she will die within next 2 to 3 days. Lo and behold, he came back after 10 days to 2 weeks, and he found that the lady was perfectly healthy. So he asked कि भाई क्या किया है? तो उन्होंने कहा कि हमने तो इस बूटी का इसको पानी निकाल के कावा पिलाते रहे. So that booty was purple foxglove, and it was responsible for extraction of digitalis and is now called digoxin. So herbs have very potential effect, and that person got digitalis registered in his name, and he became the richest doctor, William Withering, in 18th century, 1775, it is said, outside of London in UK, and bought a lot of property in Birmingham, because Worcester is very close to Birmingham. Now, what do we have if a patient has fibrosis or inflammation because of liver disease? Now I come to the treatment. Withdraw drugs or toxin. You give for viruses antiviral, and for inflammation or fibrosis because of NASH or toxins, you have 2 drugs, pioglitazone and vitamin E. Vitamin E can only be prescribed according to American Association for Study of Liver Disease, for those who do not have diabetes, because it's associated with increased cardiovascular mortality in diabetes. So what other drugs are currently under research or study? Elafibranor is PPAR agonist. Unlike pioglitazone, it is not working on gamma receptors. It is only working on alpha and delta receptors. It is anti-inflammatory, so no weight gain because it has no effect on gamma receptors. Elafibranor, 120 milligram research trial was done in NASH, 20% versus 11% resolved. It is now going through a phase 3 trial. Glitazar is a dual PPAR alpha gamma agonist. And saroglitazar is the latest, and they are undergoing clinical trials. Obeticholic acid, you must have heard about it. It has been registered now in USA and is being used for liver inflammation and fibrosis. It's a farcinoid X nuclear receptor ligand agonist, and it has proven to be effective. Selonsertib is angiogenesis or apoptosis signal regulating kinase inhibitor. Apoptosis signal regulating kinase inhibitor. The producers or manufacturers are Gilead. ये गिलियड वही हैं जिन्होंने सफॉस्पोविर बनाई और ये रेमडेसिविर भी गिलियड की है और रेमडेसिविर इज नाउ अवेलेबल इन लाहौर. अब्दुल खालिद साहब कह रहे थे कि अवेलेबल नहीं. 2300 रुपए में इट्स अवेलेबल इन द फार्मेसी. And when I was admitted with COVID, I was the first one in PKLI to have received the full course of remdesivir. Lekin I think the decision was more because of my son talking to the doctors in the hospital rather than the doctors doing it for themselves. But it is now being used and it is freely available in Lahore on the pharmacies. It is brought from India and sold in open market. Selonsertib itself, recently the results were published, has not found to be effective. And it used with one of the monoclonal antibodies, temtuzumab, the result is not yet out. So not many drugs are available. It does improve fibrosis, and then there is ipragliflozin, and then this is the last researched molecule, sarucriviroc. Sarucriviroc is a chemokine receptor antagonist. It is anti-fibrotic, it inhibits the stellate cells, and it is anti-inflammatory, it inhibits the Kupffer cell recruitment. So all the drugs too are available. Pioglitazone, obeticholic acid is also available now, and vitamin E. Now I come to the historical drug, and that is why I mentioned digitalis. There is a unique combination which has been brought now from, and it has silifos. Silifos is an advanced molecule of silymarin. The difference is it's the same thing, but it is 10 times more available. The data and the evidence says that it's 10 times more available. Artichoke, this is in combination with silifos, and artichoke is also a herbal product like turmeric. And it reduces jaundice, it improves appetite, reduces dyspepsia and nausea. And turmeric, haldi, is anti-inflammatory and has been used for thousands of years. What this combination does is that it has been proven that it conserves glutathione. And when the glutathione is increased in the hepatocyte, it does stabilize the cell membrane. It does prevents the liver cell from an oxidant or free radical oxygen species injury. So it is hepatoprotective, and this is available now in this combination. There are three components. Milk thistle is a plant from which you extract silymarin, and then you do a biochemical reaction, phosphodietyl-cholestyrinase combination, which makes it 10 times more available, and you get silifos. And then is turmeric, and according to the WHO monographs, turmeric has anti-inflammatory activity, antioxidant activity, and it has got activity against peptic ulcer and dyspepsia. Artichoke plant, this is being used, and those of you who are fond of eating pizza, all the new pizza houses like Rena's and Rena's Kitchenette and Amavi and places like that, they will use a lot of artichoke when they serve pizza. So it's a good herb which is used in cooking. It adds flavor and it has also these properties that it promotes bile production and secretion, improves the symptoms of dyspepsia, and improves the symptoms of GI distress. WHO approves artichoke as anti-hepatotoxic, antioxidant, and as a choleratic agent, which means that it promotes. Now I am coming to the last 2 to 3 slides. The product which contains, because this is an industry symposium, all three, Silifos, artichoke, leaf extract, and turmeric is live capsule. There is evidence that it has shown to protect liver against injury by NASH, injury by alcohol, and injury by other antioxidants and other drugs. A study in World Journal of Gastroenterology appeared, and the reference was also given this morning by Professor Yasun Nabi when he spoke of interventions in pancreatitis. So it shows here, this study, that the total bioavailability is 10 times more in Silifos compared to Silimarine. And it is associated with normalization of ALT in NAFLD patients in 41% cases as compared to the control group. So this is how it looks. 1 capsule twice a day. And thank you. If there are any questions and comments. Yes, sir.
My question is about statin. Now, generally, it is thought that statin, they are hepatotoxic, and so many articles are published. Now, you said that it prevents and benefit decompensation.
Yes.
Now, my question is, what is the level of evidence for this statement out of ABCD? And number 2, what is the mechanism due to which it benefits decompensation?
Okay, the mechanism, because I am not like Barry Bloomberg, whom I mentioned, won Nobel Prize in physiology, and they call it medicine. I have no idea how it works, the mechanism. I am basically a physician and go by the evidence. And the evidence was taken by Abraldis. He is a man from Spain. And it is a level A or level 1 recommendation that you should give it in patients with cirrhosis, even if they have advanced cirrhosis, except when they have decompensated. Yes, this is a meta-analysis of many randomized controlled trials. So it is a high level of evidence.
Might be an anti-inflammatory effect because in plaque in coronary arteries, statins do have a role of anti-inflammation. You see.
I accept it.
So might be
Statins, I know, are anti-inflammatory. They are anti-fibrotic and they are also anti-neoplastic.
That may be reason.
These statins have anti-inflammatory, anti-neoplastic, and anti-fibrotic effect. What I said that I did not know is how this effect is executed in the liver. But I know that for sure it has anti-inflammatory effect. Professor Bilal has to make a comment.
Regarding this statin business again, can you comment on which statin it was talked about? 1, dose was considered. 2, and regarding again for the enoxaparin bit, what dose was being considered for
40 milligram twice a day for enoxaparin for 48 months.
40 milligram, irrespective of the body weight.
Yes, that was the dose.
And for
In that.
statins, which statin was the considered?
I am not sure which statin because it was a randomized controlled trial. They took all the statins which the people were taking in patients with cirrhosis. And the dose is not mentioned, but what I practice and what I found out when I was attending that meeting, that most people recommend atorvastatin at a dose of 10 milligram to begin with. Atorvastatin 10 milligram.
The reason why I especially wanted to know what was because rosuvastatin, the next generation, claims the reversal of the atherosclerosis. So that's a different drug, and that too at a higher dosage of 40 milligrams.
Right.
So anyway,
So reversal of atherosclerosis and probably reversal of fibrosis at a low dose was manifest or given by Abraldis and 10 milligram of atorvastatin in that most of the studies which he analyzed. Okay, thank you very much.
Thank you so much, Professor Dr. Aftab Mohsin, for very productive presentation on updates on hepatoprotection. Now I would request to the chairperson कि आपके comments. जी.
By the team of all the chairperson to say special thanks to Professor Aftab Mohsin for a very elaborate talk and especially throwing light on some aspects which are not commonly practiced, like use of statins and especially throwing light on the herbal aspects of turmeric and artichoke, and specifically knowing the recipes of certain pizza outlets. So that I don't know how you come to know of it. Maybe you have some, had an extensive experience regarding that. But thank you so much, sir, for a very elaborate talk. Thank you, sir. And sir, one thing I'd just like to add regarding remdesivir. In Punjab, we were lucky to be provided remdesivir injections initially for 30 patients at Mayo Hospital by the government. That meant all the doses for 5 days, 5 days minimum doses. And that has been extended further for the next 3 months. So we were lucky at Mayo Hospital, which was catering the maximum number of COVID patients admitted under public sector, up to 415 bed capacity. So we were lucky to experiment. Actually, we are actually running a study on remdesivir. Thank you.
Ji. Ji, thank you so much. Thank you.
Bismillahirrahmanirrahim. Good afternoon, everyone. Welcome to the scientific session 4 of the day. My name is Dr. Nabil Akbar Chaudhary, and I am working as a consultant intervention cardiologist at PIC Lahore. And I will be the moderator for this afternoon covering the acute care medicine. Before we begin this session, I would like to call upon the esteemed panelists for this session. First, I would like to call Professor Abdul Baqi Durrani. Professor Abdul Baqi is Chairman Department of Medicine and Dean Faculty of Medicine at Boulogne University of Medical and Health Sciences, Quetta. Please, sir. Next, I would like to call Professor Bilal Muhyiddin. He's a graduate of King Edward Medical University and is currently serving his alma mater as Head of Department and Professor of Cardiology at King Edward Medical University. Next, I would like to call one of my teachers, Professor Tariq Wasim. He is currently working as Professor of Medicine at Akhtar Saeed Medical College. Finally, Dr. Munazza Nazir. She is Associate Professor of Medicine at CMH Lahore and AJKMC. Madam, please. So stroke is the leading cause of mortality and disability worldwide. And the economic costs of treatment and the post-stroke care are astronomical. According to the World Health Organization, 15 million people suffer stroke worldwide, and of these 5 million die and 5 million are permanently disabled. Stroke happens all the time, and yes, it can happen to you. Approximately 20% of stroke victims are between the ages of 20 and 55. Knowing the signs of stroke and acting quickly makes all the difference between saving a life and a tragic outcome. As widely known fact, time saved is brain saved and time lost is brain lost. That is why recognizing the signs of stroke is so important. Immediately knowing what to do when someone is having a stroke and to help them with what we call the golden hour. That is when someone is having a stroke, we can, because that has the greatest chance of surviving in the initial management. To further talk about the management of acute stroke, I would like to call one of my teachers, Professor Artichoke. He is ex-head Department of Neurology and King Edward Medical University. He has 28 years of experience of neurology under his belt and is one of the leading neurologists of the country. Professor Artichoke.
Thank you very much for the introduction. Bismillahir Rahmanir Rahim. So I'm going to talk about very common topic, and everybody should know about it. And in Pakistan, we are about 20 years behind what is happening internationally. So I always show this slide for BIA, Alai Rabbi Kumat wa Ziban. किस किस नेमत को ठुकराएंगे, बुलाएंगे, और इसकी सबसे बड़ी नेमतों में अल्लाह ताला की सेहत सबसे बड़ी नेमत है. एंड हमें इसकी प्रिवेंशन के लिए और इसके ट्रीटमेंट के लिए क्विकली एक्ट करना चाहिए. सो आई विल स्टार्ट विद माय पर्सनल एक्सपीरियंस, एंड आई वाज डूइंग माय क्लिनिक at National Hospital Lahore, evening time 8:30. I was called from our post-op unit that one of our professor, gynae and obstetric, he finished with surgery. He was in reviewing the case in the recovery room and he collapsed. And they called me, okay, just come and see that patient. I went there and I found that he never had any risk factor for stroke, no history of hypertension, diabetes, ischemic heart disease. And he had altered GCS with 10/15, global aphasia, dense right hemiplegia, the power was 0/5. The other vitally, all the parameters were normal. So we did immediately CT scan, and nobody was available in family. Two of his sons, they are in America and they were American born, and wife was visiting them. So he was alone here. So the question arises, what will you do? Our young doctors are here. And I always ask them, okay, out of these 5 options, so what would you choose if you are the treating physician? Will you give Disprin, loading dose of clopidogrel, start anticoagulation, or some other option, or physiotherapy, and just put him in ICU and monitor? And so any brilliant PG can answer this question, A, B, C, D, E. Any option? So no reply, so we move forward. So any other option, and that is TPA. We don't talk about TPA in Pakistan. First, because this is not available in Pakistan, we are getting it on personal hospital-based approval from DPA, from DRAP, but DRAP is too slow. It has been applied for more than 3 years. I have personally persuaded it. And now the matter has gone to cabinet. And because of Corona, everything is pending. And you will see the Corona killed about 6,000 people in Pakistan. And how many people are killed by stroke. But stroke is not our priority. So at 9 o'clock, we started him on tissue plasminogen activator. Next morning when I examined him, he was back to normal. And he is now back to his normal surgeries, no residual deficit, and he's doing fine. And this is, he voluntarily give consent for this video that I want to make awareness in this country, not only for public, but also for the doctors as well. इसमें है ये इसकी हेलो इसकी इसकी ऑडियो है ऑडियो नहीं काम कर रही
10 बरस से या 15 बरस से कह लीजिए मैं
So this is the real story by the patient.
मैं डॉक्टर अवैस फारूकी पिछले 10 बरस से या 15 बरस से कह लीजिए मैं पेस्ट हूँ I was quite happy, patient was settled, and as soon as I was coming out from the recovery area, I collapsed. मेरी राइट टांग लगता था कि मैं उसको उठा नहीं सक रहा था कोई पेन नहीं कुछ नहीं कोई प्रीवियस हिस्ट्री नहीं That's the whole story. तो वहां से I happened to be in the right place at the right time and they took me to I don't remember on a wheelchair या stretcher उठा करके मुझे सीधे वहां ले गए उनके पास एक डोज पड़ी हुई थी टीएमबी की सीधे ले गए वहां पर जहां पर मुझे सीटी किया तो फौरन एक जो डोज पड़ी हुई थी उनके पास उन्होंने चेक कर दी So the time of my collapse and receiving the injection, that saved my life. Though it wasn't then we found out later on in my MRIs and so on, that there was no single clot. It was a shower of clots. मेरा पैगाम ये है चाहे वो यंग हो ओल्डर हो कि देर ना करें That's a vital factor. And if you're living around in a city जहां पे and don't go to smaller hospital, go to a major hospital. But what about the people who live outside main cities? By the time they will come, पहले तो local जाएंगे, बेहोश है, out. तो जितनी delay होगी, administration of that injection, तो उतना ही नुकसान होगा. So this is not for investors. This is for the welfare of the society.
So this is the message. Time is brain. We should come to the hospital where facilities are available. And I think we should have the stroke unit in Azad Jammu Kashmir as well. And this has been discussed that 15 million people suffer stroke each year and 6 million die. And every 2 seconds, there is one stroke. And every 5 seconds, one person die of stroke and second leading cause of death due to stroke worldwide. 1/3 of the strokes are permanently disabled and which is an economical burden for the family. And sometimes the stroke sufferer is the only cause deficit to one person, but whole family is ruined in certain circumstances. And the managing cost of these patients who are handicapped is about 100,000 per month if you are keeping nurses and other staff to maintain these patients. The situation in Pakistan, about 450 stroke occur every year and 150,000 die. So you can see in Corona, we have only 6,000 deaths and we spend billions and billions and approval of drug in days. But stroke, nobody has so far. Government has not, we have requested every part, has not come up with the approval of TPA in Pakistan. and 20% are less than 40 years, which is a young age for the stroke. So I will not go into detail, but mine just 80% of the strokes, 85 are ischemic stroke due to thrombosis or embolism, and 15% are hemorrhage, 10% intracranial, and 5% subarachnoid hemorrhage. So I will talk mostly on the ischemic stroke. What happens? Blood supply to the part of the brain is interrupted, and 2 million neurons are lost for every 1 minute delay. So you can imagine that what is happening. This is the brain immediately after the stroke, and you can see light pink area is the penumbra, salvageable area. And as it goes after 15 minutes, dark pink area, which is the dead tissue and which is called as infarction. It appears with passage of time, it gets bigger, 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 bigger. And this is a situation that salvageable area is less, and most of the area is permanently damaged and dead tissue. So that is why we say time is brain, and the first hour is the golden hour. If anything has to be done, it has to be done as early as possible. And how can we do that? We can do it by early restoration of blood supply, either by IV TPA or mechanical thrombolysis using certain stent retriever devices like penumbra device, Mercy drive, or combined approach. First give TPA, do angiogram, see residual clot, remove it. So this is the guideline which are updated in all over the world, and even some part of the world, if you're not offering TPA to the deserving patient, then you are medically sued. But this situation does not exist in Pakistan. And this is the criteria. Now inclusion is very simple. You just need a simple CT brain and measurable neurological deficit, and the duration up to 3 to 4.5 hours. And exclusion criteria are those risk factors which can lead to bleeding, like recent surgery or INR. And extension of 4.5 hours is in selected cases, like patient should be less than 80 years, should not be diabetic, should not be having history of prior stroke, and he should not be taking any oral anticoagulant irrespective of PTIN or APTT. And this is mechanical thrombectomy, which can be done ideally 6 hours, but can be done in selected cases even up to 24 hours. And this is the result. Like those patients who are placebo, you can see 38% has 0 to modified Rankin scale from 11.9, compared with half of the patients are nearly normal after TPA. Same is the death rate from 21 to 70%. So the reduction in the death and functional outcome is much better in those patients who receive TPA. And intravascular endovascular intervention, you can achieve up to 59 to 88% of revascularization. And dose is 0.9 milligram, maximum 90, 10% you give as bolus, 90% as infusion. So this is one aspect. So we don't have TPA like in this part of the country. So what will you do? I tell you a lot of things in non-TPA management done by the doctors are actually contributing to the worsening of stroke. And you will answer this question at the end of this talk, that how we as a doctor contribute to this worsening of stroke. ABC for every patient, whether it is neurology or cardiology or any patient. So you have to ensure airway, breathing, and circulation. Antiplatelet, there is no strong evidence that patient who receive first dose of aspirin within 48 hours, they do better than those patients who do not receive it. And then these are simple 4 things: fluid therapy, blood pressure management, glucose control, and fever. 4 simple things. And these 4 simple measures can improve outcome like TPA. IV fluid, we recommend only normal saline, no dextrose, no dextrosaline, naringas, because it aggravates cerebral edema, increased lactic acidosis, hyperglycemia, and poor outcome. Blood pressure, cornerstone of acute ischemic stroke management. Now, this is important. Cerebral perfusion depends on 2 things: mean arterial pressure and increase in intracranial pressure. After the stroke, intracranial pressure will rise, so the cerebral perfusion will decrease. And if we increase the mean arterial pressure, cerebral perfusion will be maintained. So this is the important thing. to know, because skull is a hard area. It will not expand because of edema. So you have to manage by maintaining the cerebral perfusion. And this is the normal autoregulation. Normally, if blood pressure fall to 60 degree, brain will not suffer. Autoregulation will maintain it between 50 to 150. So no ischemia. But when stroke occurs, this autonomic failure is gone, cerebral autonomic. There is a linear relationship. Increased pressure, increased blood flow, and increased cerebral perfusion. So now we are depending on high pressure to maintain cerebral perfusion. And if you suddenly lower that blood pressure, so what will happen? Cerebral perfusion will be impaired and ischemia will get worse. And reactive hypertension, this is a natural response to stroke. Most of the patients after the stroke will have high blood pressure. Not necessarily they are hypertensive and stroke is causing this problem. So recommendation is, if you want to give TPA, then BP should be lowered, 180 to 110, less than 10. And non-TPA patient keep around high. Only treat if it is more than 220 by 120. Lower BP in certain situation, like acute MI, LVA, you have to reduce the eclampsia patient, hypertensive encephalopathy, acute renal failure. But if these condition does not exist, then leave that pressure. It will automatically come down normal. And if you have to control by 10 to 15% within first 24 hours. Not that you bring it zero. Now, what is common practice which I see when the patient comes to me? Patient comes with acute ischemic stroke, fully conscious, walk to the ER, seen by doctor on duty, blood pressure 215 by 15, family worried. The ER doctor is even more worried. BP is very high. So given sublingual capotin, Adalat, IV furosemide, started Dexul water. So everything. So what will happen? BP come down to 120/80. Now patient family is very happy. ER doctor even more happy and even proud. What happened to patient? Patient worsen, he has complete aphasia and he is not able to power is 0/5. So and then he is referred to KDM neurologist ke paas chale jaye. So now you analyze, and same is blood glucose. We need to recognize that hypo and hyperglycemia can mimic stroke. And secondly, it can worsen stroke. So maintain blood glucose between 90 to 140. Temperature. 1 degree rise in temperature, it doubles the poor prognosis. So you, irrespective you find any cause or not, stroke itself can lead to fever. So you have to keep the patient afebrile, give them paracetamol regularly, and keep the patient afebrile throughout the course. Swallowing is the major cause of death in these patients. So you have to recognize the patient is not able to swallow, put NG tube or keep them NPU for 24-48 hours. And statins, early use of statins, like statins are very favorite nowadays. Even in stroke, there is study that if you start on the first day, there is improved survival. Neuroprotect, lot of things. Patient calm, Neutropil, alpha-choline, fluorocholine, they are given to the patient. No evidence that these things work for acute stroke. And steroid, they do not benefit the patient. Even the heparin is not a treatment except if it is embolic stroke. Stroke unit is the need of the time, like CCU. There is study that patients who are kept in stroke unit, they do better, outcome is better, they survive better because there are people, doctors, nurses trained to recognize aspiration, to prevent DVT, to prevent bed sores. All the complications are recognized early, are they are preventable, are recognized early and treated early. So every hospital should have a stroke unit, which is a geographically designated area only for the stroke patient. And then this is a study which is called FEST protocol. You see, they did not do anything. They just concentrated on the fever, sugar, swallowing. 3 factors they controlled, and you see with only this one, 15.7%, which is significant p-value, and they were more likely to be alive and independent at 90 days stroke, post-stroke. So you can see that these simple measures can improve the outcome even if you do not have TPA in your hospital. And finally, stroke is not a single neurologist job, it's a multidisciplinary. Many allied specialties are involved, like you may have consultation for cardiologists if patient has atrial fibrillation and heart myocardial infarction. You have speech therapists, you have physiotherapists, you have occupational therapists. So you have a rehabilitation program, but time is short. I can only tell you that this and how to achieve education, fairness of doctors and public. Recognize sign of stroke, rush to hospital fast, stroke code after arrival in hospital, acute stroke unit, and you should have a stroke team, which should include neurologists, neurosurgeon, neuroradiologists, physicians, speech therapists, etc. So this is, we have few awareness program in Pakistan. So I finished here. Thank you. तो इसके बाद अब आप जिन्होंने स्ट्रोक ट्रीट किया वो देखें, जो नॉन टीपीए पेशेंट में आपकी वो जो एक स्लाइड है, फ्लूइड कौन सा दिया, बीपी कितना लो किया, टेम्परेचर का क्या हाल था, एस्पिरेशन का क्या हाल था, वो अब आप अपना अपना ऑडिट खुद करें and see what is the difference. Thank you very much.
Thank you, sir. But since the next session is basically on more on the cardiac side, so if there are any questions from the audience regarding this stroke issues, please feel free to ask Professor Saab right now. Mike. Role of TPA for posterior circulation strokes.
Irrespective whether this is posterior anterior, ischemic stroke, just if you say okay, this is a patient of ischemic stroke, there is role of TPA.
Probably the limiting factor over here for her is that a CT scan is not that good as far as a bleed for the posterior aspect is concerned.
No, the CT scan is good for any hemorrhage in the brain, whether it is posterior circulation, whether it is subarachnoid hemorrhage. So we don't need any big gadget. Plain CT is good if it is done within 24 hours. After 24 hours, yield is low. And we do CT scan not to see the size of the infarction. We just want to see that CT there is no blood. And CT will show infarction after 24 hours. So the idea is only no hemorrhage.
Professor, for a long time, when this lytic therapy came in, the first one on the tool was the streptokinase, which came in, and the cardiologists jumped onto it. And they did show a certain amount of benefit. Yes, other drugs did come in, and they have shown a better benefit. Somehow the other neurologists never considered streptokinase as a safe.
No, this is not. These are all international based studies. Now the first study was done on urokinase, then streptokinase, and then TPA. These are and those studies were disaster. Yani the bleeding rate was 20% in urokinase and streptokinase. Even with TPA, the bleeding risk is 6 to 7%, but the mortality is about 1 to 2%. So these are all evidence-based. And one more thing I may add, now the Canadian neurologists, they are doing international studies, and Pakistan part of this one, where they are starting the reusing streptokinase, and there are some ethical issues getting approval, but this is being again re-evaluated nowadays. Professor Shoaib हैं, Ishfaq, वो हमारे कनाडा के वो डायरेक्टर हैं स्ट्रोक के, तो he started this one again.
Professor Aziz साहब के लिए माइक से बेटा के लेकर.
I had a question that if somebody has clinical stroke and with CT we actually prove that this is not hemorrhagic stroke and we assume that this is ischemic. Is there any possibility that this is not stroke at all? It's just like there's some seizure. Sometimes migraine can present with paralysis.
Again, this is like differential diagnosis of stroke. Like you give 20 minutes, I can only want to talk only this thing. But like differential diagnosis, every neurologist has to consider. Khas taur pe hypoglycemia. I had one patient coming from Bhavalpur landing to me. Nobody checked blood glucose and he has hemiplegia. His blood glucose was 1200 something. We treated hemiplegia and he was normal. Same happening with hypoglycemia. So hypoglycemia, hyperglycemia, post-ictal phase, कि अगर seizure के बाद Todd paralysis है. So this is the job of the physician to differentiate between this one. But I tell you, even if you ignore, I will still start considering, you must consider any paralysis. Now, what are the warning signs? Anything had me suddenly, चाहे वो VN में है, speech में है, आपके hemiplegia है, numbness है, anything happens suddenly mean minutes to hours. This is stroke until proved otherwise. This is the clinical definition. And CT normal. And even if you have made a wrong judgment, but I will benefit the patient, treat as stroke patient. This is internationally accepted, like psychogenic stroke. Now people have given TPA to psychogenic stroke because disaster and wrong diagnosis in stroke has a very poor outcome and bad prognosis. So internationally psychogenic are getting TPA. So you have to consider that.
Last question, please.
Sir, Talha Shabir, House Officer Ames. Sir, I needed to ask one thing. If you just put in TPA within 3 to 4.5 hours, in cardiology, we sometimes come across the reperfusion injury. So is there any incidence of reperfusion injury here in the brain, and what are the symptom signs and what can we do about it?
What is reperfusion injury in stroke? That is hemorrhagic transformation. When you restore the blood supply, the area of dead tissue is necrotic. Blood-brain barrier is ruptured. So a sudden rush of blood, it will lead to hemorrhagic transformation. But luckily, the rate of this reperfusion hemorrhagic transformation is 7%. And mortality out of these are minor hemorrhagic transformation. And the death occur in only 1 to 2%. So that is happening. But again, if you fulfill the criteria, you must give TPA because you will never have the chance to walk again and become normal. So everybody should go. We should promote this. We should have at every level. Now we have tried. Now the matter is lying with the Ministry of Federal Ministry. I hope it will be approved within once the corona is over. So, but this is the time we should talk about TPA, not Disprin. We should talk. We should demand about TPA, and we should talk about simple stroke unit. What is stroke unit?
Right, sir. Thank you, sir. We have to push off to the next one. And one person is above the less than what the otherwise mortality would have been. Giving a TPA, you end up with a bleed. You still have a mortality of 1%. That is still less than what otherwise the mortality would be. So with that, back to you.
Thank you, Professor Athar, for a wonderful presentation. Acute coronary syndrome, ACS, refers to a group of conditions that include ST elevation MI, STEMI, non-STEMI, and unstable angina. Some form of coronary artery disease can be asymptomatic, but ACS is always symptomatic. Chest pain is among the top reasons for the emergency department visit still. Coronary heart disease and acute coronary syndrome remain widely prevalent and still is top cause of death of people over age of 35. It is essential that providers all over the world maintain a high degree of suspicion and vigilance while assessing patients with possible ACS. Along with this, public education and recognition of symptoms is crucial. To talk more about acute coronary syndrome, I would like to invite on stage Professor Imran Saeed. Professor Imran Saeed is Head of Department and Professor of Cardiology at Rawalpindi Medical University. Professor Imran Saeed.
Bismillahirrahmanirrahim. So I'll utilize this time. So talking about acute coronary syndrome in 20 minutes is just like sailing an uncharted ocean. So I think I'll restrict myself to some basic things, and I see lots of young doctors here. And my focus of attention will basically be these young, bright, young doctors who are future consultants. Now, before I start my presentation, I would like to thank the Society of Internal Medicine for providing me an opportunity to be here with you at such a glamorous place like Muzaffarabad with lovely weather outside. ताकि यहाँ बैठ के हम दिल की बातें करें. Cardiologist is a dil ka mehram. So I'll be talking. So I'll be talking about role of arterial remodeling in acute coronary syndrome.
या डॉक्टर साहब को पानी लाके दो उधर से.
Any success? अच्छा.
ऐसे कर लो नवीद,
जी.
अभी ताहिर नवीद की लगा दो और इनकी जो है ना इसके बाद कर ले. Let them try to do that. Let's get Tahir Naveed online and Ingo. In the meanwhile, Professor Saab is still with us, sitting over there. If there are any further questions regarding the stroke part, if anyone has any further queries. So the stroke trial that you are mentioning about, the SK that is coming up, is this the one in which they are going for the higher dose of aspirin and half dose of the lytic therapy that was initially administered? Trial. Mike, Dr. Saab ko yaad do, please. Professor Saab ko mic.
This is purely using streptococcus. Generally, when you give thrombolytic therapy, we as a neurology, we don't recommend any antiplatelet for 24 hours. So this is purely for the streptococcus.
And one last question before he starts off his presentation. Cardiologists like 75 at the most 100 and then some 150. Neurologists usually go with the same patient at 300 milligrams of aspirin. Can you shed some light on it in view of the fact why the difference, and then if someone has both the problems, what to do?
I think there's no major difference. The approach by the cardiologist and the neurologist are almost same. Only difference is in the thrombolytic therapy. Yani you people are very happy with streptokinase and it works very well. And for us, the otherwise dose you can use 75 milligram. The recommended dose is even recommended from 50 to 300 milligram. And the other difference is that you cardiologists like dual antiplatelet, but for neurologists, so far the guideline says use only single antiplatelet, either Loprin or clopidogrel, or you can use dual antiplatelet if there is TIA or minor stroke with complete recovery. So you can use for 3 months. So these are the two differences. But again, those patients who has undergone stenting and other thing, so we continue with the for stroke patients, single antiplatelet therapy is recommended.
Clopidogrel carries 25% resistance, 25 to 30% resistance. Would you like to consider, sir?
Because we have not evaluated this in neurology, but since we are more limited to aspirin, very rarely we use combination unless it is required for the cardiac purposes.
Sir, very kind of you. I think the arterial remodeling in ACS is ready now.
So coming back, दिल के मामले अजीब होते हैं. Acute coronary syndrome is very confusing. You know, whenever I talk about acute coronary syndrome, it reminds me of pizza. Yeah, I don't know about the gradients, but you know, it's there. You know, it comes in a square box, yet when you open it, it's round. And when you start eating it, it's a triangle. Life and people are like pizza, look different, appear different, and of course, behave absolutely different. And that's how the acute coronary syndrome presents. हर दर्द जो सीने में उठता है वो दिल का दर्द नहीं होता. Because there is a long list of differential diagnoses, जो सीने का दर्द करती हैं. And do you know how many of the patients they present with typical chest pain? Somewhere around 60% or 65%. What about the rest 35%? इसीलिए मैं कहता हूं कि हर दर्द दिल सीने में नहीं होता. Because they present with angina equivalents. There are patients who present with shortness of breath with no chest pain. They can present with simply numbness in the shoulders or numbness in the wrist or numbness in the jaw or back of the chest without typical anterior chest pain. So for young doctors, always remember, cardiology is practiced not only with basarat but basirat also. So you have to dig in to see what this pain is. So you have to have a right approach for that. So what is the spectrum of presentation? The spectrum of presentation is, on one end of the spectrum, there are patients who present with absolutely painless infarct or painless ischemic episodes. And on the other end of the spectrum, there are patients who die suddenly within seconds. So anything in between is there whenever you talk of acute coronary syndrome. For this, you are talking of something for which you have to be very vigilant, and you have to see the patient not only with your eyes, but with your heart also. So ischemic heart disease, I usually discourage my young doctors and students to use the term ischemic heart disease in a generalization. Because, you know, ischemic heart disease is a very broad spectrum thing. Ischemic heart disease, it consists of stable ischemic heart disease and acute coronary syndrome. Acute coronary syndrome, it consists of unstable angina and MI. And MI can be ST elevation MI or non-ST elevation MI. And then, depending, it's a right ventricle infarct or left ventricle infarct. Or, depending upon the side, anterior, extensive anterior, anterolateral, and the list goes on. And so, end of the spectrum, you have multiple entities. So, you always define your patient के उस spectrum में आपका patient कौन सा है. And that is very important because there are differences in the management and planning of the patients of all the different agents of the spectrum. So develop the habit, especially I'm talking to the young doctors, that you should develop the habit of specifying the exact point on the spectrum to which your patient belongs. And whenever we talk of ischemic heart disease burden, it consists of years of life lost from ischemic heart disease deaths and years of disability lived with 3 of the non-fatal ischemic heart disease sequelae. And that includes non-fatal acute MI, angina pectoris, and ischemic heart failure, which is increasing day by day. Now, this is a slide you must have seen lots of time in right from your pathology classes. And this shows you how the most important thing in coronary vessel or cardiovascular system, that means endothelium. It starts with the dysfunction of the endothelium, and one of the important factors which leads to endothelial dysfunction is increased concentration of LDL itself. So through the cascade of events, ultimately, you reach at a point when you have a full-fledged atheroma developed over a period of time. These are the multiple factors which act, react, and interact to ultimately lead to coronary atherosclerosis. I'll not go into the details. And typically, in case of ST elevation MI, there's a plaque rupture, thrombus formation, lumen occlusion, and ultimately leading to infarct. No, but when does it start? It starts right from here. You know, it's the first decade of life. Always remember, अभी डॉक्टर साहब ने बात की stroke के मतलब time की. No other field of medicine is so much dependent on time as cardiovascular problems are. In cardiology, our slogan is race against time. You have to strike first to win the race. And if you have to win the race, you have to strike here, not here when you are at this stage. You know, this thing doesn't occur in a day. वो कहते हैं ज़माना बरसों परवरिश करता है, हादसे अचानक नहीं होते. You had to act here to prevent this. Now, historically, the focus of diagnostic evaluation for symptomatic patients has been the detection of an obstructive coronary stenotic lesion. कि ये नजर आ गया, ठीक है, ये बैलून किया और स्टेंट कर दिया, and that's all. However, two challenges to this approach have resulted in revision of this evaluation algorithm and provided added insight into the burden of atherosclerosis and overall hazard of ischemic heart disease events. First, the clinical trials, they show that GDMT, that is guideline-directed medical treatment, is safe and that revascularization may be deferred for patients who are suffering from stable ischemic heart disease. I'm not talking of unstable angina or unstable disease. I'm talking of stable ischemic heart disease or stable angina. That means strategies of either revascularization with optimal medical therapy or optimal medical therapy alone are effective in improving the symptoms of the patients and removing the burden of angina. Second, there is unfolding evidence of the clinical and prognostic significance of non-obstructive lesion. What is a non-obstructive lesion? Non-obstructive lesion is basically any lesion which is less than 50% of occlusion is known as non-obstructive lesion. This is what typically occurs in the coronary vessel. One of these four things usually occur whenever there is acute coronary event. And most of the cases, the first two and rarely these two can also occur. This is the ruptured fibrous cap, and this is superfusion leading to the clot formation. Now, disruption of plaques that may not produce critical stenosis causes many acute coronary syndrome events. The point is, it's not always the obstructive lesion which causes acute coronary syndrome event. Most of the time, it is the non-obstructive lesion which causes the issues. And the credit goes to the females, again, for this discovery. It was seen that males, they have more obstructive lesions. However, the mortality or the event rate was low. Whereas in the females, there were more non-obstructive lesions. However, the mortality and the coronary events were on the higher side. So they dug into it and ultimately came to the conclusion that it's not always the obstructive lesion which is of problem. We have to manage the non-obstructive lesion also. These advances have altered our concepts and of clinical approaches to both the chronic and the acute coronary phases of coronary artery disease. Now, previously considered a simple collagen disorder, coronary atherosclerosis now is classified as an inflammatory disorder. It's not a simple matter of deposition of cholesterol and leading to obstruction. It is basically an anti-inflammatory, and the wealth of data available, evidence available that it is basically inflammation of the atheroma which leads to disruption and lead to consequences. Now, what is arterial remodeling basically? Now, if you remember the first slide in which I showed you the endothelium, traditionally it was considered that the atheroma, it develops and gradually protrudes into the lumen and causes obstruction and lead to events. And it was thought that external elastic lamina, which is beneath the media, is a fixed entity. And whenever there's deposition of cholesterol or atheroma formation, it always protrudes into the lumen. However, histological studies have demonstrated that certain plaques do not reduce luminal size, presumably because of expansion of the media and external elastic membrane during atheroma development. This phenomena is called arterial remodeling. Now, if you see, this is normal vessel, this is deposition of atheroma, this is big atheroma, but still the lumen is patent. It still increases in size and it hardly affects the lumen. But this atheroma is there, and it can ultimately lead to shrinkage and can lead to in the shrinkage of the lumen. Similarly, look at in this view. Now, in the reference is if whenever there is a ratio of healthy vessel taken from the external elastic membrane outside, if the ratio is more than 1.05, you call it positive remodeling. And if the ratio is less than 0.95, you call it negative remodeling. Whenever there is expansion of the external elastic membrane outside, it leads to positive remodeling. Whenever there is shrinkage of the elastic membrane, it leads to negative remodeling. Now, the important thing is, if it has been seen that the patients who have negative remodeling, the atheroma cap is usually thick. Whereas patients who have positive remodeling, the overlying cap of the atheroma is usually, it's a thin cap. And this thin cap is more liable to rupture and give way, leading to acute coronary events. Whereas this being a thicker cap, it is less likely to give way and rupture, leading to coronary events. Now, expansion and shrinkage of coronary vessel is an important process in the coronary artery disease. The process of arterial remodeling is fundamental to the pathophysiology of coronary artery disease in a native coronary lesion and after interventional procedures such as angioplasty. Now, the point is, a patient who has a big atheroma burden, आप उसको 15 मिनट भी एक्सरसाइज टॉलरेंस टेस्ट करवा लें तो वो नेगेटिव आएगा. वो सारा दिन भागता रहे, एक्सरसाइज करते, he'll be asymptomatic. And you must have seen numerous patients in your clinics जहाँ पे a patient comes to you with these reports that he has negative exercise tolerance test. Even at times they can have negative perfusion tests also, because there is no compromise in the perfusion. And a few days later they present with acute coronary events. और आपको समझ नहीं आती कि हुआ क्या, इसके सारे टेस्ट तो ठीक थे. So the point is, you have to consider the patients जहाँ पे उनको risk factors हैं. So anyone with the risk factors for ischemic heart disease, the major risk factors, you always consider to look for other signs of ischemic heart disease. ठीक है, वो किसी ने कहा था ना कि किसी की आंख जो पूर्णम नहीं है, न समझो ये कि उसको गम नहीं है. If he doesn't have a stenotic lesion, that doesn't mean that he cannot have acute coronary event. He must be harboring a huge ischemic burden in his heart in the form of very high levels of atheromas. You see, this is thrombus and atherosclerotic plaque. Similarly, this is a stable plaque, which is a thick, very thick cap. Although the lumen is tight, but still it is a thick cap and it is less likely to produce ischemic acute coronary events. Whereas this is a big lumen, big lipid deposition, but a thin cap. This is positive remodeling in this scenario, and this is liable to rupture and lead to acute coronary events. And as you see, the histology is thick cap, small lipid core. Now, what are the practical implications? A stable plaque with less than 50% stenosis is usually asymptomatic. Stable plaque with more than 50% stenosis can have stable angina. And unstable plaque, even with less than 50% stenosis, can lead to unstable angina or acute MI. So the point is, we have to learn how to approach the patient. Cardiology is not all that simple. Acute coronary episodes are not simple. As I mentioned earlier, it comes in different forms. You have to see your patient not only with your eyes, but with your heart also. You have to dig in and see the basic pathophysiology with which the patient presents, and you have to suspect it in all those cases who have the risk factors for ischemic heart disease, because it's a matter of race against time. Thank you very much. Any question? Okay, thank you.
Thank you. Thank you, Professor Imran Saeed, for our elaborative talk. Cardiac CT has developed into a robust clinical tool during the last 15 years. The advent of cardiac CT has introduced a new practice of diagnostic paradigm, being the most accurate and non-invasive method of identification and exclusion of GAD. Furthermore, the detection and of subclinical coronary artery disease and the plaque imaging after the opportunity to improve risk stratification. Recent advances of the latest generation CT scanners allow combining both anatomical and functional imaging by stress myocardial perfusion. The role of CT is in acute setting is already very important and become progressively more important in the coming years. To talk more about this, I would like to call on stage a person who was the most feared during our fellowship exams. We used to say he will take out his USB and you're going to fail. So, but he's a wonderful person at heart. Dr. Tahir Naveed. Dr. Tahir Naveed is an associate professor of cardiology at PIC Lahore and is heading the cardiac imaging department of the Premium Cardiac Institute of Punjab. Dr. Tahir Naveed.
Bismillahirrahmanirrahim. Thank you, Nabil. Thank you, organizers. Now I have to talk about the imaging. The imaging role of coronary artery disease. My task was to talk about the chest pain. So chest pain is one of the most commonly evaluated symptom by the cardiologists, primary care physicians, emergency physicians, pulmonologists, and it is most commonly researched symptom by the patients also. Lot many patients visit the emergency department. We have a very busy hospital. We are at a tertiary care premier hospital of cardiology, and almost we receive maybe one patient every 5 minutes or 2 minutes. So this is the US data. More than 6 million patients are visiting the emergency department, and it's the most common symptom to visit the A&D department. So this is a PQRST pain assessment tool. I think students will be very liking it. It is easy to remember, and PQRST, as you know, is the ECG trace. So P is for position, and where is the pain? Can you point it? What provoked the pain? What makes the pain better or worse? What were you doing when the pain started? So these are the questions you can ask to your patient just to evaluate the pain. What was the quality of pain? Whether it was dull or squeezing, pressure-like, burning, aching, various kinds of symptoms, character he can have. Then radiation is very important. and severity. And you can rate this severity on a scale from 0 to 10. 0 mean no pain and 10 mean a severe pain. You can rate it. We do it in the emergency department frequently, that how much pain you are having. And time, how long have you had this pain? Was the onset slow or it was sudden? This is very important in case of, especially in case of chest pain, because ischemic heart disease can have variable, presentation. If the pain is, gradually built up, most likely it's a coronary syndrome. But if the pain is sudden in onset, the aortopathies should be ruled out. So the onset is very, very important to ascertain. Triage these patients who present in the emergency department. The purpose is to safely discharge or admit the patient. The purpose of the triage of the patient is whether you want to go to admit the patient or you are going to discharge the patient. So early and accurate triage in the emergency department of patient presenting with acute chest pain, it is the difficult job. We do have various set of parameters like biochemical markers, ECG, chest X-ray, echo we do, and we use the various combination of these and try to sort of triage these patients. These are the important causes already talked about: acute coronary syndrome, which should be ruled in or ruled out during an emergency visit. So chest pain can have various presentations in combination or in isolation. Like you can have a pressure in the chest, or isolated jaw pain, shoulder pain, abdominal pain, and also the associated symptoms should also be evaluated with this chest pain. Essentials already know the history, clinical examination, ECG, biomarkers, and these are the imaging parameters with which you evaluate the chest pain. So I will be concentrating on the MDCT. So what was the need for MDCT? Current consensus is that you should have a test which can safely, exclude the diagnosis by which you can, either admit or discharge the patient. So you should have a test which should have a high negative predictive value, and it should be cost effective, should be efficient, and should preferably should be a non-invasive test. MDCT is such a test which is a non-invasive method that quickly and accurately assesses the cause of chest pain and shortness of breath, and substantially improves the ability to triage these patients who have presented in the emergency department with chest pain. The scanners which are able to do these things should be at least 64 and above slice, and these scanners have ability to do the ECG gating, and they have the sub-millimeter spatial resolution and good temporal resolution. With this, you can have a very good image of coronaries and aorta, with which you can rule out the important pathologies of chest pain. So they provide adequate and comprehensive assessment of coronary artery anatomy, aorta, pulmonary arteries, and MDCT provides relevant findings in the context of differential diagnosis of chest pain. So there are some limitations also, that it is a contrast-based, study. And patients who are unstable or having tachycardia or have arrhythmia, you cannot do a scan to these patients. And the one who are unable to hold the breath or in a very serious condition, you will not be able to do it. And plus the renal dysfunction. So I will show you a few cases to prove my point. This is a patient who is 35 years old, gentleman, non-smoker, hypertensive, history of postprandial chest pain. He was having frequent visits. So EGD was done, which was reported positive at high workload. And there were some ECG changes also. We did the CT because, so you can see these are the CT images. This is the VR image. This is the angiographic view, and these are the coronary arteries. This is LAD, RCA, circumflex, obtuse basal branch. So you can very well see the lumen of the artery, and when you have these kind of images available to you, so you can very safely discharge these patients. So he was just advised, risk factor modification, and this is a 40 years old gentleman, smoker, BMI 26, chest pain, frequent emergency visits, ECG always normal. His ETT was also reported as abnormal. So again, CT, he was referred for CT. This is a curved view of the coronary arteries. This is LAD, circumflex, RCA. So you can see over here, there's a calcified plaque over here, but the luminal narrowing is not much. And this was a suspicious lesion. So we did a thallium scan for this patient just to assess the severity. And thallium scan came out to be normal. There was no reversible ischemia in the LAD territory. So again, patient management was that he should have a medical management, just a risk factor modification. Again, chest pain, 40 years old gentleman, no risk factor, BMI 28, he was slightly obese, and clinically okay, ECG normal, referred for coronary disease evaluation. Now in this patient, when we did the CT of this patient, so this is the left coronary cusp, this is a VR image, and this is the left brain stem, and you can see the right coronary artery coming from the left coronary cusp. And this is the origin of right coronary artery. But the important thing is that this is having a malignant course. It is in between the two arteries. This is the pulmonary trunk, and this is the aorta. So these patients can have exertional, symptoms of ischemia, and can have arrhythmias also. So this is an important, finding. And when you have this finding, then you can, risk stratify these patients. Again, a patient who had AVR 2 years back, and he was on warfarin therapy, presented with day 1 MI. He was thrombolized, and the problem was that he was on warfarin and his INR was 2.5. So we could not do the conventional angio. So just to see the coronary anatomy in this patient, we did the CT of this patient, and this is the LAD, this is the infarct-related artery. You can see this is there's the occlusion over here, and the rest of the LAD is okay. We could assess the function of the valve also. So this is the diastolic frame. You can see the optimal closure, and the systolic frame. There is adequate opening. So valve function was okay, but there was a clot also in the LV apex. So we assess the function, and we assess the coronary anatomy. So CT can even, assess the coronaries in a post-ACS, post-MI situations also. 27 years old young gentleman, hypertensive, non-smoker, presented with chest pain. Blood pressure was 150/90, clinical examination normal, ECG unremarkable. Again, referred for the assessment of coronaries and aorta. So when we did the CT, normal coronaries, this is the VR image of the aorta. So you can see there is no aneurysm dissection in any segment of aorta, and there is no coarctation. So with one test, you can, rule out so many things, coronaries, the aortopathies, and you can reassure the patient and, send him back. So no aneurysm, no dissection. And this was a young bureaucrat, and he had chest pain during a tennis match. So that pain settled, and then he came back. He was not, the pain was very typical, but he was not, he did not opt for the invasive angiogram. We did the CT, and we could find this lesion in the LAD. This was a bifurcation lesion over here. So then he was, stunted. And he had this stent. This is the angiographic view, and this is the post-PCI. So CT is. This is a very interesting patient. She had PCI of the RCA. And after 1 year, She again presented in the emergency. And the consultant thought probably it is the stent which is, causing the symptoms. So they referred this patient for the stent evaluation. So we did the CT angiogram, and the this is the stent in the right coronary artery. And you can see the stent is perfectly fine. The rest of the right coronary artery is okay, but she had developed this left vein disease. So over here, there was a tight osteostenosis of left vein. So these are the various views where the left vein was stented, and this is the post-PCI image of the same patient. Again, a chest pain patient having, frequent emergency visits, CT done, and this is the significant myocardial bridging. Left pain stem, and then this is dipping into the muscle and coming out. This is almost a vertical dip. So it's a very significant, dip in the muscle. And so again, once you know it, then you can start the beta blockers on these patients, or maybe sometimes they require a surgery. So this is a very interesting patient, 75 years old gentleman, non-hypertensive, non-smoker, non-diabetic, and had a severe chest pain anteriorly and in that interscapular region on the backs of 6 to 8 hours duration. This was associated with sweating, shortness of breath. Pulse was 80 per regular or equal on both sides, but blood pressure was too high, and the rest of the examination was okay. So ECG was okay, troponin was okay, and but on the X-ray you can see this is the slight mediastinal widening. And we did the CT with the dissection in our mind to rule out the dissection in this patient. This is the CT view. This is the aortic valve, root, proximal ascending aorta. This is the proximal ascending aorta. This is the descending aorta. So no dissection could be seen in this patient. But there was a slight thickening of the distal ascending aorta and arch. So this is basically a type of a dissection which is intramural hematoma, which is more evident on this delayed image. So over here you can see this. This is the delayed image, and you can see this eccentric thickening. Eccentric thickening is just, it's a diagnostic for intramural hematoma. So it was a patient of dissection. Did not have the dissection flap, but it had the dissection. The coronaries were perfectly fine of this 75 years old gentleman. So CT findings were intramural hematoma without dissection flap, and moderate to single vessel disease, normal LV function, no pulmonary embolism, normal aortic valve, LVH. So this all we could determine on a single CT exam. This is a post-PCI, this is the graft. Again, post-PCI chest pain presenting to the emergency. Troponin was negative. We did this CT, and you can see this blackening over here. This is a hypoattenuation in the graft, which is a sign of ISR. So this patient had an ISR in the graft. Over here, you can see this. This is post-cabbage patient, chest pain, Lima graft. This patient had first the PCI of LAD, this occluded, followed by he had a cabbage. And after cabbage, 3 to 4 years down the line, he had again chest pain. So we did the CT angiogram, and the graft was okay. But just after the graft, in the native vessel, there was a tight lesion over here. So this was causing the symptoms of chest pain for this patient. 53 years old gentleman had aortic root aneurysm causing severe AR. So during angiogram, they could not engage the right coronary artery, and patient started having severe chest pain. So the procedure was abandoned, and the patient was referred to us. So we did the CT, and this is the dissection flap over here, dilated root, non-coapting aortic valve, and then this patient had the root replacement. This is a patient with pulmonary embolism, so you can very easily rule out pulmonary embolism on a single CT test. This was a very interesting patient, 20 years gentleman. He had first episode of severe chest pain while doing a field work. and presented in the emergency in the early in the morning. So we did this CT, and this had a severe, this is the dissection flap, this is a VR image, and he also had this cause of hypertension, this is coarctation. So coarctation, dilatation of the root, and dissection flap. Again, a patient of dissection. So you can also assess the complications of, dissection. This is a dissection flap, coronary artery, and this is the pericardial effusion. This patient was referred for evaluation of dissection, and this patient also had this intramural hematoma. I will just, again, a patient of dissection. The VR image, this is a dissection causing the left vein occlusion. So dissection, can be completely evaluated on a CT, single CT. This is a patient with pericardial effusion. So pericardium can also be assessed on the CT. This is the VR cine image. This is post-MI pericardial effusion. Post-MI, this patient had a MI of anterior wall. This is this scarred myocardium. This is the clot, LV clot, and this is the post-MI pericardial effusion. These are the delays. So in conclusion, MDCT is an important investigation for chest pain evaluation. It can do early triage for discharge or admission, and it can help in the prompt diagnosis and determines the prognosis. Thank you.
Thank you, Dr. Naveed. As always, huge collection of images. Okay. The number of patients on mechanical ventilations has increased in modern cardiac ICUs. And as a result of increasing complexity and comorbidities, these patients have increased chances of mortality. And thorough understanding and ventilation management is essential for practicing cardiac intensivist. So to talk more about the assisted ventilation and cardiovascular disorders, I would like to invite our speaker, Professor Rizwan Abid. Is he here? Sorry. Professor Rizwan Abid did his MBBS from King Edward Medical College, and he is currently working as Professor of Cardiology at AJK Medical College. Professor Rizwan.
Thank you very much. It's really pleasure and honor that Pakistan Society of Internal Medicine invited me as a speaker. There's no conflict of interest, nothing to disclose. CCU has evolved. There was a time when only myocardial infarction, arrhythmias, and defibrillation was carried out. But now it has transformed into a cardiac intensive care unit called CICU, where you find a lot of comorbid conditions like sepsis, respiratory failure, stroke, and similarly, the modalities of treatment have also been added apart from the conventional therapies. So now CICU, cardiac intensive care unit, is more appropriate word for CCU. If you are able to appreciate that what happens after cardiac arrest when there is return of spontaneous circulation, it is called ROSC. Don't hyperventilate. So there are ifs and buts and hiccups while putting a cardiac patient on assisted ventilation, because you have to be within certain limits. And probably once famous proverb that please don't, if you can't provide benefit to the patient, please don't harm the patient. is particularly true about when you put a patient on assisted ventilation. The conventional wisdom is don't hyperventilate after cardiac arrest. No, post-cardiac arrest, you have to avoid hypoxia, you have to avoid hyperoxia, you have to avoid hypocapnia, you have to avoid hypercapnia. So this is a very, very complex setting. And now, why normocapnia? Because hypercapnia can lead to several vasodilatation, can lead to raised intracranial pressure, and can worsen the metabolic acidosis. Similarly, hypocapnia can cause cerebral ischemia as a result of cerebral vasoconstriction. Now, role of N-tidal carbon dioxide in CPR. Just the recent evidence shows that just crossing the vocal cord by endotracheal tube is not enough to warrant that the endotracheal tube is really in exact position. So there has been now EtCO2, N-tidal carbon dioxide, which guides you. And this is also called capnography. The normal range is 35 to 40. And normal range of PaCO2 in this post-cardiac arrest setting is 40 to 45 millimeter of mercury. In a patient who has survived cardiac arrest, you have to maintain oxygen saturation more than 94%. Initially, FiO2 is 100%, PaO2 is 100%, and later on you reduce according to the clinical status of the patient. Keep oxygen saturation equal to above 94%. These are ideal mechanical ventilation settings in a post-cardiac arrest patient. Minimal tidal volume, 6 to 8 ml per kg. The value of carbon dioxide, the value of oxygen, and later on you keep on reducing FiO2. So, if EtCO2 and tidal carbon dioxide is less than 10, then you are worried. Patient is not going to survive. And if it is more than 30, then you can expect the survival of the patient. So just, this is most important slide. What happens during spontaneous inspiration? There is increased venous turn, there is decreased right ventricular afterload, and there is increased left ventricular afterload. This is observed during spontaneous inspiration. Now, when you start positive pressure ventilation, the effects are reversed. There is decreased venous turn, there is increased RV afterload, and there is decreased LV afterload. One very important difference is between the right ventricular response and left ventricular response. So, starting positive pressure ventilation in a patient with isolated right ventricular failure is not an easy decision. The mortality is very high as compared to starting positive pressure ventilation in heart failure due to left-sided lesions. Because the beneficial effect of positive pressure ventilation is on the decrease in LV afterload. Now, imagine what happens in the weaning. The effects are essentially reversed now. So this is the reason that cardiovascular patients are difficult to wean. Because once the positive pressure ventilation is withheld, the LV afterload starts rising, and patient can develop weaning cardiogenic pulmonary edema. Again, what happens in SIMV, very commonly applied word? that is synchronized intermittent mandatory ventilation mode. Here, you allow patients breath synchronization with the mechanical ventilation delivered breaths. What would be the effect of spontaneous patient breaths? They have different effects on RV afterload, LV afterload. And then you are synchronizing with the positive pressure ventilation. So this kind of ventilation is now detrimental and is not recommended in acute coronary syndrome, in ischemic heart disease, and in cardiogenic shock. You can use volume assisted ventilation and pressure assisted ventilation. But SIMV mode is now not getting popularity because the effects of the physiological effects of normal spontaneous breathing and a positive pressure mechanical ventilation breathing, they are different, and they can worsen the clinical status of the patient. So this is again the repetition of the same. This is very important because if you don't know, you will only harm the patient. They have different effects on the right ventricle and separate effects on the left ventricle. This is very important when you put a cardiac patient on the mechanical ventilators. Now, what is respiratory failure? Respiratory failure is a syndrome where either there is defect with the oxygen uptake or carbon dioxide elimination. When it is hypoxemia, this is called type 1, and when there is hypoxemia and hypercapnia, this is called type 2 respiratory failure. And cardiogenic pulmonary edema remains an important cause of hypoxemic respiratory failure. Now, before considering invasive mechanical ventilation, the assisted ventilation can be started with non-invasive ventilation. It can provide time for the cause of respiratory failure to resolve. It can overcome the auto PEEP, which is nightmare for critical care specialist, intensivist, anesthetist. It can unload the respiratory muscles. It can decrease dyspnea, avoid endotracheal intubation because it is non-invasive. This is the difference between non-invasive ventilation and mechanical ventilation or invasive mechanical ventilation. That in non-invasive ventilation, you don't put the endotracheal tube. And it augments tidal volume, it overcomes intrinsic PEEP, it stents the airway, reduces carbon dioxide production. But there are a lot of ifs and buts and hiccups. In cardiopulmonary arrest, it's contraindicated if there is hemodynamic instability, if there is electrical instability. Non-invasive medicine can't, mechanical ventilation can't be used. Similarly, if there is recent facial trauma, deformities, GIT upset, vomiting, airway obstruction. So there is a long list of contraindication for non-invasive ventilation. Although it is much safe because it is non-invasive. There are different modes of non-invasive ventilation. CPAP and BiPAP are most commonly used. And there are different varieties of non-invasive ventilations. And each varieties have their own benefit, their own advantages and disadvantages. So I won't go into the details. In cardiac patients, usually we use CPAP and BiPAP. Then what is PEEP? PEEP is the same, positive pressure ventilation, but in mechanically ventilated patients. Otherwise, they are same. They are providing positive pressure. And recently introduced high flow nasal cannula. This gained popularity particularly after COVID and this pandemic. Is also used and can, but it's costly and it's not available readily everywhere in the country or everywhere in the world. So this is costly and there are problems about the availability of this high flow nasal cannula. This is also a form of non-invasive ventilation. You gradually increase the, in BiPAP, if you utilize BiPAP, you gradually increase the and titrate 2 to 3 centimeters, and you avoid IPAP and EPAP. This is inspiratory portion. The maximum limit is 20 centimeters, and other is EPAP. And you start from 5 centimeters, the ratio is 1:2. If the patient is put on CPAP, CPAP is usually given for hypoxemic respiratory failure. BiPAP is used usually for type 2 respiratory failure. There is hypoxemia as well as hypercapnia. Now, what about heart failure? When you see a patient with heart failure in emergency department, you have to ask 2 questions. First, after ABC, is the patient in cardiogenic shock? And next is there any problem with the ventilation? Is the patient having respiratory failure? This is according to most recent guidelines, European Heart Failure Guidelines 2016. So the things have changed now. You have to give due consideration to the respiratory failure. If you see the bottom end, intubation is recommended if there is respiratory failure leading to hypoxemia, if the PaO2 is less than 60, if there is hypercapnia, PaCO2 is more than 50, or acidosis, if pH is less than 7.35. So now in heart failure, the conventional wisdom was just Lasix, digoxin, morphine. No, the matter is not so simple. You have to see the patient, you have to look for the respiratory failure as well. You have to, and then you can devise the ventilator strategy. Non-invasive ventilation should be avoided in acute myocardial infarction, hemodynamic comprise, and if there is depressed mental level, if the conscious level is not, the GCS is down. This is mechanical ventilation for cardiac surgery patients, but this is just there are settings, and in the interest of time, we can't discuss it here. This is a mechanical ventilation setting for cardiac surgery patients. So, in cardiogenic shock, these are the ventilator settings which are safe for the patient. And how you assess invasive mechanical ventilation. Use of pressures, arterial blood cases, X-ray chest, auto PEEP, patient comfort, and winning possibility. This was Card's shock study. Probably the only main randomized control trial, which was multi-center, done in 9 countries. It randomized 220 patients with cardiogenic shock, with 81% of the patients had acute coronary syndromes, and 19% were non-ACS. And mortality was 43%. The mortality due to cardiogenic shock, this was a controlled environment. This was a randomized controlled trial. So imagine our settings, which are not controlled, the real-time mortality is very high. The mortality due to shock was 43%. It's very high mortality of cardiogenic shock. There were 3 groups. One was conventional oxygen therapy, other was non-invasive ventilation, and one was invasive mechanical ventilation. These are the baseline characteristics of different patients. And the mortality was high in invasive mechanical ventilation group as compared to non-invasive group and conventional oxygen therapy group. This is acute cardiovascular guidelines, European guidelines of acute cardiovascular, recently published in 2020. And after diuretics, ventilation. So recent guidelines have emphasized that in cardiac shock, in heart failure, you have to see and decide about the ventilation as well. Now, what about the weaning of ventilation, ventilated patients? If there is difficulty in weaning, then there are different therapies. If the patient has coronary disease, vasodilators, COPD, then consider, and with hypertension, you can consider nitrates. There's hypertrophic cardiomyopathy, beta blockers, and calcium channel blockers. ARDS, particularly observed in COVID pandemic. So you start from non-invasive, early intubation, deep sedation, then proning and ECMO. So they are beyond the scope of this talk. So now there are certain ethical issues. We should get that. Is it appropriate to extend mechanical ventilation in anticipation of brain death for organ donation like cardiac transplantation? There may be conflict or disagreement. Because in this particular case, if you extend the mechanical ventilation, this may not be the interest of the patient. Because you are doing for the others. What are the other important issues? They are level of competence in ventilatory care, end of life care, how to transport mechanically ventilated patient, and how to perform CPR in mechanically ventilated patients. But they need a separate session. So thank you for your attention. If there are any questions, I will appreciate it.
Thank you for the lovely talks. I'll request all the three speakers to kindly be available. So before we go to the panelists, may I first request the audience if they have any queries for the ACS, the MDCT. Sir, please. Also,
there's a housekeeping announcement before that. As we are running short of time, there will be only 4 or 5 questions. And
45 questions.
There will be a session after this, which will have a lucky draw, and you can try your luck being there. And that after the session, there is a high tea. So please, questions, please.
4 or 5 questions means 45 questions. Yeah,
sir, not by you.
45.
Not by you, sir. No.
Sir, I have a question from Dr. Tahir.
Tahir?
I have a patient. He is diabetic. He's having exertional dyspnea. थोड़ा सा बाथरूम तक जाने से भी shortness of breath हो जाती है. He is creatinine उसकी around 2 है. तो उसको हम कैसे evaluate करेंगे? He is on bronchodilator, inhaled steroids. उससे कोई उसको improvement नहीं हुई. How should we proceed further?
I think as far as CT is concerned, we need to have a normal renal functions for that. And angio भी उसकी ज़ाहिर है वो नहीं हो सकती. So I think it should have a, echo. I mean, you can...
Echo is normal.
You can...
Echo हो चुका है उसका.
And he's having...
X-ray chest में वो कोई pneumonitis वगैरह लिखा हुआ था और कोई चीज़ नहीं. X-ray chest भी हो चुका है. Echo भी normal है उसका. He is obese, he is diabetic.
The disease, disease modifying factors, treatment optimization, that is what you can do. As far as imaging is concerned, I think he's a very optimal patient for this CT angio.
I think first thing we have to decide is it pulmonary or cardio?
Yeah.
To me, it looks like a pulmonary problem. And for that, HRCT is great because that does not require contrast.
Dr. Imran, would you like to take up the answer? Professor Imran.
देखें जैसे मैंने पहले कहा कि हर दर्द जो सीने में उठता है वो दिल का दर्द नहीं होता.
और बहुत सारे सीनों में दिल भी नहीं होता.
हाँ बिल्कुल जी, absolutely. So the point is, just Dr. Sir, first you have to decide whether it is cardiac or not. So then it comes to your clinical approach. Okay, I'm coming to that. Now, once you have decided that the patient is having symptoms because of his cardiac problem, then you have to proceed. Although the criterion is on the higher side, but you have to see what is the risk-benefit ratio. Whether you have to dialyze the patient and go for angios, side-by-side dialysis and coronary angiogram. Instead of going to CT angio, you can even plan for direct angio and intervention in the presence of dialysis. So these are all clinical scenarios depending upon the status of the patient, status of the myocardium, and your suspicion case may underlying ischemic burden kitna hai. And obviously in this scenario, you have ruled out कि non-cardiac causes नहीं हैं. So that's my point of view.
Currently, the new definitions of myocardial infarction, the universal guidelines, which are divided into 5. The first one is, of course, the atherosclerosis one, which is the one that we have all the time. The second is the high demand, and the third is when you don't have enough carriers in between. That is to say, you may be anemic or you may be with hyperthyroid problems. So there are always other possibilities to be considered, and then the basic fact that would the patient perform on a basic ETT, how is the performance? So from there you can evaluate that if this patient gets short of breath, he is going to have a positive ETT at a very early. So may actually be he may actually be a non-atherosclerotic type heart failure patient, type 3, which may be there. Next question, please. So I think with that we have start concluding this session.
Yes,
Sir, your comments, please. Sorry. Question over there.
My question is to Professor Rizwan. Like we face this problem nearly every day. Post-cardiac arrest, post-cardiac surgery patient on ventilator, not weaning off. And the relatives are sent to us saying everything is fine from our side. Now talk to the neurologist. And where should patient go? Like, would you like to keep him same place where he had issues, or should we shift to the other hospital? Like, he will not come off until his weaning off is there. So every day this is the issue.
So actually, in my last slide, I discussed with you the ethics. The ethics of putting a patient on a ventilator and when to extubate. So the initial counseling is very important. The counseling should be done because you can't take the consent of the patient. You have to take into account the beneficence, the autonomy of the patient. And you can't take the consent from the patient. You have to discuss
ventilation is always done on merit.
Yes.
Patient needs ventilation.
Yes.
You don't need any consent.
Yes.
Patient need ventilation,
Yes.
and that is on merit.
Yes.
Problem is weaning off. Now weaning off, if all the brainstem reflexes are intact and patient is not clinically brain dead, we cannot take him off the ventilator unless desired by relative and they consent.
Yes.
Okay, patient is.
Yes.
But sending that patient, shifting the responsibility to others, that our job is done, and now this is.
I think the answer to that question will further be answered by Professor Tariq Wasim about the brainstem reflexes not being responsive.
This is ethical issue.
I mean, just a comment. We usually have this situation in our intensive care units that the patient has been put on vent, and of course, most of the time there is no purposeful neuronal recovery, and then when to put him off, right? So that I think that's the area where probably we usually send a call to the neurologist to assess for the say, to document the brain death. Then we probably ask the intensivist as well what to do. So this is probably a gray area where who should be. So I think the definition that's brain death that's given is that it has to be at least 2 persons. One has to be neurologist, one of the intensivist, and none of them should be possibly the primary treating physician of that patient. So I think the Atar would be more elaborating on that. That is it the way we practice it?
Mike, please.
This is a criteria that clinically the two people should verify brain death and examination at least 6 hours apart. And among these two, none of them should be treating physician or anybody who is involved in the renal transplant team. They should not be part because there is conflict interest. When this PKLI was being legislated, so we have completely laid down the criteria for the brain death, and that has been approved by the Punjab Assembly. So it is part of this one, and these are the criteria. And but what I'm talking about is not the brain death. Patient is alive, and shifting the responsibilities. That is totally different thing, because that creates some sort of between relatives, cardiologists, and neurologists, but some sort of thing that nobody is taking the ownership of the patient. And while the patient is lying within the cardiac institute, so that creates some kind of this thing. I think we should something on this as well.
So you're basically referring to regarding the patient being okay, needing ventilation,
yes,
and you have to shift the patient somewhere else.
Because cardiac surgeon will come, I have done surgery, is successful. Interventional cardiologist will come, look, post-angiogram, doing fine. Intensive say, the patient is not being ignored. And now this is neurology, shift to the neurology. But shifting a patient on ventilator from a cardiac institute to the other one is something not easy thing.
It's not an easy thing, but now luckily you have these mechanical ventilators available which are portable.
I know that.
And
I know that. What I'm talking about, let me then put straight away this thing, which I do not want to say. If you are working abroad, complications are everywhere. But the ownership never shifts. Like if I am a cardiologist, something happened there, I will take the responsibility till I will take the opinion from neurologist, but I will keep patient under my care and intensive.
So the primary physician is the one who's responsible for everything.
One of your answers is that in the West, there are two proformas available. One is POLST and one is MOLST. When you are initially putting a patient on ventilator, everybody knows that mortality on ventilator is very high. You get signature. In this proforma, there is written, don't resuscitate. And there are a lot of information. So initial counseling is very important. My answer to your question is that initial counseling is very important. You get a signed signature from the proxy of the patient, the attendant who has taken responsibility. And you will discuss about to resuscitate.
Thank you, Dr. Rizwan. I think in the need of time, now we have to just ask Imran's comment.
So the thing which you are doing is very important and very crucial, but the point is we are dealing with people जिनको BP line डालने के लिए आपको consent लेनी पड़ती है और वो negative होती है. And you are talking of issues which are, which need a lot of counseling and discussion and all those things. So I think we need to educate our people first, and only then things can improve. I don't know in coming future हम कैसे इसको करेंगे. The thing, they are not in a good shape.
Thank you, Professor.
Right. Thank you. May I request Professor Dr. Bhakti Ranwani to kindly make his comments.
Thank you to all of our speakers. This session was actually the heart of the meeting. And this is why that there was a rich discussion over it. And there were learned presentations, presenters with very informative presentations. I'm really thankful to all, and this panel is thankful to to you all. With this, we will end this session.
May I have your comments, please?
I work here as an associate professor in an AJKMC. We had all the wonderful presentations on all scientific sessions today. So saying something in front of you, such an legends, I am unable to say anything, but I would only like to pay my thanks from core of my heart from my juniors and my colleagues coming here and enlightening us. And thank you very much, sir, all of you. Sitting with you, I am feeling excited, embarrassed. I can't say anything. Thank you very much.
Thank you. May I request Professor Tariq Hussain?
In the interest of time, sir, I would like Professor Bilal to conclude. Mega interest of time, Dr. Bilal to conclude early.